Coming to you from the Dietitians and Nutrition Support Dietetic Practice Group, this is the DNS Member Podcast, where we explore topics relevant to our field. From support line content to nutrition celebrity interviews and everything in between, this podcast is where DNS members can go behind the scenes and explore the driving forces behind cutting-edge nutrition support. I'm your host, Christina Rollins. Let's get started. Hey everyone, welcome back to the DNS podcast. My name is Christina Rollins. I'm your host, and today we're joined by Vanessa Kumpf to explore the role of parenteral nutrition in managing patients with enterocutaneous fistula, also known as EF. Vanessa is a clinical specialist in nutrition support at Vanderbilt University Medical Center in Nashville, Tennessee. Coincidentally, where DNS DPG will be joining colleagues literally from around the world later this year in October for the Academy's Food and Nutrition Conference and Expo. Vanessa earned her Doctor of Pharmacy degree at Creighton University and completed a nutrition support residency at Medical University of South Carolina. She's an author, a speaker, and a very well-known voice in the field of nutrition support. So I'm so very excited to have this conversation with her today. Vanessa, welcome to the DNS podcast. Thank you so much for being here with us.
Thank you so much for the invitation.
So can you start by defining what an EC fistula is and how it impacts nutritional status?
Good. Let's start with an easy question. I like that. So an enterocutaneous fistula is really just an undesirable connection between the GI tract and the skin. And, so there's contents within the GI tract are leaking and they're trying to find an exit out. It's just the body's way of working out this leak, this undesirable leak. And the reason for a leak is it's typically, or most often, it's either a surgical complication, some type of abdominal surgery where the anastomosis breaks down, or it may be a patient that's just got diseased bowel, like a patient like with Crohn's disease, such as fistulizing Crohn's disease. Those can actually track out to the skin potentially. So that would be also defined as an enterocutaneous fistula. And the way it impacts nutritional status really is simply causing a disruption with nutrient absorption. So nutrients are being rerouted, if you will, out to the skin. So really that extent of malabsorption depends on the location of the fistula within the GI tract.
What are the primary goals of nutrition support in patients who have an EC fistula?
Really the primary goal when you think about patients with an EC fistula, wound healing is really of primary importance, and nutrition status really impacts this wound healing. And then the other really primary goal is potentially many of these patients are going to require future surgery. And we know that nutrition plays a major role in impacting surgical outcomes. So kind of when you think about those two goals of wound healing and preparing a patient for surgery, that's really where we need to focus nutrition and making sure we have adequate nutrition in these patients. And essentially all of these patients are at risk of malnutrition because not only they have this fistula, so malabsorption from the fistula, but many of these patients are obese. And that, leads to even more challenges. And when these patients, many times they've got these prolonged hospital stays, having difficult ambulation because of the fistula itself. There's problems if, getting up, where there's leaking from the fistula. So when you think about that, prolonged hospital stays, difficult ambulation, then these patients and obesity, these patients are really at high risk of sarcopenic obesity. And that then leads to this spiral of further muscle weakness and poor function. So that's really why nutrition support is so important in these patients.
So at what point in a duration of care, if you will, is parental nutrition in particular indicated? And then how do you kind of figure out the best time to initiate it?
Okay, this is really a difficult question.
Mhm.
And unfortunately, there's no simple answer to this question. So I'm going to it's really very multifaceted, this condition of an EC fistula. So I'm going to kind of go through the thought process of when PN is indicated and the timing approach. So really, when patients initially present with a fistula, oftentimes they're in the ICU, they're critically ill. PN is really indicated in this setting with this initial presentation. And the reason why is because, first of all, we want to know the extent of that fistula as far as what the output is. And the quantification of fistula output is really important in our long-term plan of how to manage the fistula. So if we um, place the patient at bowel rest, there's no influence of GI stimulation in this case. And so that's really where bowel rest initially with PN is helpful. Um, so the other thing, not only does it allow you to quantify fistula output, but it also, this strict bowel rest with initial presentation also allows you time to stabilize the fluid and electrolyte balance in these patients because they really have high fluid needs, high electrolyte needs. So it kind of helps us to allow time to help stabilize that balance. So then thinking beyond that, if you have a patient who experiences really dramatic decrease in fistula output with that strict bowel rest, then the thought is that if we continue strict bowel rest, we may be able to promote spontaneous closure of the fistula. And really that's really the ultimate goal is to close the fistula without more surgery, just spontaneously allow it to heal and close. Otherwise, again, you're going to be looking at surgery down the road. So bowel rest, strict bowel rest can really help achieve that outcome. But as the condition continues, patients may be appropriate for diet or tube feeding, uh, maybe alone or in combination with PN, although there are certain caveats to that, like when is it appropriate for diet or tube feeding. So we need to make sure that there's adequate bowel or absorption that's in continuity. We also want to make sure we can maintain fluid and electrolyte balance with a person eating or on tube feeding. It's going to be a little more challenging. And then we want to make sure that that fistula output is controlled so that what I mean by that is that it's adequately pouched, it's not leaking, there's not breakdown of the skin at the site. All of those things are more difficult to achieve with a patient who's eating or on tube feeding. And this is really where input from the surgeon is going to be fundamentally important. We really have to work with the surgery team to determine indication for PN and the timing or when it's appropriate to initiate diet or tube feeding. It's not something that can be done in isolation. It really needs to be done in collaboration with the surgeon.
So what are some key considerations when initiating PN in this population?
Okay, so as I mentioned, many of these patients are critically ill with the new onset. And so when we think about nutrition support or the PN, what the requirements are, it's really advised or recommended to utilize, what you do in other critically ill patients. So when you determine the energy and protein requirements. So if, the ASPEN and SECM adult critical care nutrition guidelines are a good resource to use. As I mentioned, many of these patients are obese, and so we need to factor in their weight and adjust the requirements based on their obesity, so weight adjusted. With protein, we really want to aim for high protein because they're losing a lot of protein from their fistula output, and they have high demands for wound healing, high demands of protein for wound healing. So we want to be aggressive with protein, but energy, requirements are a little bit more tricky because a lot of these patients have, risk of hyperglycemia. So we need to be cautious with our dextrose dose in these patients. Their risk of hyperglycemia, like I mentioned, many times they're obese, they have a history of diabetes, they're critically ill. We use octreotide in a lot of these patients to help minimize or to hopefully decrease fistula output, and octreotide can lead to high blood sugars. So many of these patients are at risk of hyperglycemia. So we really need to be cautious on our dextrose dosing, and we may need to add insulin to manage that. And really using a balanced energy with carbohydrate and lipid is helpful. And with lipid, using a fish oil containing lipid source is recommended, especially in this critically ill acute setting. I would consider using that and making modifications as you go. Oh, and then, so that's protein, energy. Fluid and electrolyte requirements are going to be high in these patients, accounting for that high fistula output or whatever the fistula output is to compensate for that. They're losing a lot of electrolytes, fluids, micronutrients, and so we need to account for that. In this acute setting, it's often unstable when we initiate PN, so don't expect to manage everything with the PN early on. It's really many of these patients are going to require supplemental IV fluid or supplemental IV electrolytes. And really just close monitoring, intake and output monitoring, laboratory monitoring is required to make that adjustment. And then finally, just a note about zinc, because zinc is something that is lost with fistula output, and depending on how high that output is, there may not be enough zinc in the multi-trace element cocktail that only contains 3 milligrams of zinc. And so empirically, we typically add more zinc for patients with an EC fistula.
As you're doing your initial assessment and you're evaluating where the patient's EC fistula is located, and then kind of thinking through your follow-ups as you're watching that fistula output, how do those parameters or changes influence your strategy and your overall management of the patient?
Yeah, both of those are critical. That fistula output, the quantity of fistula output, and the location of the fistula really are critical. They are really helpful in determining the appropriate route of nutrition. So parenteral, enteral, tube feeding. So they're very helpful when we're trying to figure this out. So first of all, when we think about the fistula location, so there's different imaging studies that are done to help identify where the tract is originating. And it could be the stomach, small bowel, colon. So it really helps to identify uh, the origination so that we can determine if there's enough bowel available for absorption. So, for example, a patient with a gastrocutaneous fistula, that then allows for placement of a feeding tube into the small bowel, and we can feed patients tube feeding in that setting. Patients with a distal fistula, so a colocutaneous fistula, there should be adequate small bowel available for absorption. So those are patients that are likely to tolerate oral diet or tube feeding. But those patients with a small bowel fistula are going to be more challenging to have adequate bowel length for absorption. And then when we think about fistula output, it's typically classified as either high output or low output. Greater than 500 mils per day is considered high output. Less than 500 mils per day is considered low output. So if a patient has high output, they're going to be more likely to fail the oral or enteral route. And those are going to be the patients more likely to require PN. First of all, it's really harder to maintain the fluid and electrolyte and nutrient, macronutrient requirements without the use of PN because they just don't have enough bowel for absorption. The other thing is when these patients eat that already have high output, it makes their output even higher, and it's sometimes difficult to maintain proper pouching of the output, and that's a problem. those with low output, less than 500 mils a day, those are going to be your patients more likely to tolerate an oral diet or tube feeding.
We talk a lot on this podcast about multidisciplinary teams and how important that team approach and effective communication is in providing that safe, great patient care. So, can you help us understand specifically the multidisciplinary team as it relates to patients with EC fistulas?
Yeah, I think the multidisciplinary care is really critical in this setting because these patients are so complex. And first of all, let me start with the surgeon. Okay, the surgeon is really going to be the key person identifying the overall plan of care. And, it helps anybody managing that patient to know what that plan is. So, are we attempting spontaneous closure of the fistula, or is the plan to take this patient back to surgery? And then the timeline for that is so important because so and usually the surgeons will know that pretty early on. They may say at the onset, this patient is not going to be going back to the OR for at least 6 months. We have a patient right now, they're saying it's going to be a year before they're going to go back in and do surgery because, otherwise it's just going to lead to more complications. So they need to allow, pretty prolonged time before they would go back to surgery. So, or you may see, okay, we're going to attempt closure of that fistula. We're going to give it 3 months, for example. And if it doesn't close within 3 months, then we're going to consider taking the patient back to surgery. So the plan may evolve over time, but it's good to know as that where you initiate, where that plan is going to start, and then how it evolves over time. That's really the surgeon is going to be key in that for that aspect. Nurses are really important here from the wound and stoma care. Nurses with experience in wound and stoma care, not only on that inpatient side, but then in the home or the outpatient setting too, finding a good clinic where these patients can go to. Because if that pouch breaks down and is leaking, then it really creates a lot of problems, not only with the skin, irritation of that skin, but getting those patients up and ambulating. And then finally, the multidisciplinary nutrition support team is critical. So, really, this applies to both the inpatient and the outpatient setting. So, even if you've got this experienced team, like if you're working in the critical care arena and you're managing, they're very complex in the ICU setting, and you need somebody with expertise in that critically ill patient, how to manage their fluid electrolyte nutrient requirements. But then you also need somebody that you can hand off to and who can continue to manage that patient in the long-term home setting. Like I said, many of these patients are on PN for months to, a year. So, or longer. So, really having, like in our center, we've got a multidisciplinary intestinal failure clinic where we manage these patients. But if patients don't have that resource available, then they're going to require expertise from the pharmacists and dietitians in the home infusion pharmacy to help guide this process. So it's somewhat fragmented, much more fragmented, I think, in the outpatient setting. And that's unfortunate, but it's the reality. And so we really need to do the best we can to take ownership of that as nutrition support clinicians.
So, as you are, as you said, owning these cases and really helping the patients for, weeks, months to a year or more, walk us through your approach to really managing those fluid and electrolytes as you're infusing that TPN.
Yeah, so I already kind of alluded to this, in the acute setting where their losses are, unstable and tend to be kind of high or higher. We don't expect the PN to be able to replace all of that. Oftentimes, it's not stable or compatible to try to do it all with the PN. So we really need to utilize supplemental fluid and electrolytes. And we utilize a protocol for our fistula fluid replacement protocol, and it is kind of based on a ratio. So it's something that a standing order for the nurse to be able to replace fluid based on fistula output on 4 to 6 hour intervals. So somewhere between, if you look at a ratio of fluid to fistula, somewhere between 0.5 to 1 or 1 to 1. So if like, let's say in a 4-hour period, their fistula output was 500, then if you were matching 0.5 to 1, then you would give 250 mils of saline, for example, or LR, some kind of fluid replacement. That makes it just kind of an automatic way to maintain hydration. So you have a stable amount in the PN, but then you're also matching based on output, which is nice if it's unstable. And then we do, close laboratory monitoring and um, intake and output monitoring to help guide that. And then as we work to stabilize that output, so we use medications to help decrease output. I mentioned octreotide, but really any antidiarrheals can be used to help decrease output. Then hopefully we're getting to a place where then the PN can be used more as a way to meet their needs within the PN itself, because we want to try to ultimately prepare them for home. And so this is a way to help prepare them for home. We still may need to do some supplemental fluid on the side, but at least we can try to maintain as much as we can in the PN as we stabilize their output. One of the things too that I wanted to mention here is that a lot of these patients, they'll complain of really excessive thirst. Their body's all confused. It doesn't understand. They're not taking in fluids and they're thirsty and they've got all this output. But if patients are allowed to drink, which at some point, the surgeon may be allowing the patient to drink fluids or clears, just be really careful, because what happens is when they drink, they may be pulling more secretions out than what they're taking in, and it may be working against you in trying to maintain hydration. So oftentimes we have to fluid restrict these patients. We want to give them something for comfort, maybe ice chips, something, popsicles, sometimes they do, but to help control that thirst. But really limiting fluid intake is an important way to hopefully decrease the output.
Are there any other specific complications or risks that you see associated with the prolonged parenteral nutrition in this population?
Yes, certainly there are risks. But I kind of feel, if you're using PN appropriately, the risks of not using it are probably greater than the risks of using it. So it's obviously that risk benefit, but it really provides them a lifeline, I think. When you think about risks, the biggest one for these patients really is a central line infection, especially when they've got all of this GI secretions and output and maybe leaking. And, they're certainly at a high risk of central line infections. That's the biggest concern. So we really have to be diligent with our central line care. But if you think about the risks of the fistula itself, because these patients are all at risk of, just based on the fact that they have this fistula, they're at risk of malnutrition, they're at risk of dehydration, electrolyte abnormalities. So, when you think of PN, if you're not using it appropriately, then you're not managing these risks, or their risks may be higher. But hopefully, again, if you have this multidisciplinary experienced group of clinicians, hopefully there's going to be less risk and more benefit.
So just a couple of questions left. How do you approach a patient who's maybe ready to transition from parenteral to enteral nutrition, or even start their oral intake whenever it's feasible?
Okay, so really, I guess the easy group of patients to think about is the patient where the fistula has resolved. What do you do with once the fistula has resolved? So this could be spontaneously or with surgery. So with uh, the patient who has a spontaneous closure of the fistula. So how do you know that? So you're monitoring output. Oh, they're reporting decrease of output, and then there's nothing coming out, zero output. Typically, the surgeons are going to do some imaging to make sure things look good from that standpoint. We're feeling pretty comfortable that the fistula has resolved. We really rely a lot on the surgeon here for when to allow a patient to start eating. So when they're given that clearance, typically it's going to be a small amount of like full liquids or soft diet is typically what our surgeons will allow. Again, just a small amount, monitor for fistula output, and then kind of advance from there. It may just be like a few weeks. It may be longer. It kind of depends on the patient, what that timeline looks like. If it's a surgical repair, if patients have gone back to the OR and have had successful repair of that fistula surgically, typically they may they may still need PN in just as a short-term bridge because you think about like some of these patients it's been months since they've actually had food. So you can't just like flip a switch and say, okay, now you can start eating and they start eating. Well, it does take time. And when you think about a lot of that bowel has been out of continuity, so it needs time to adapt. So it may be a slow course in getting them back to eating. We sometimes we have to send the patients back out on PN and then monitor for how they're doing with their eating and slowly start cutting back on the PN, giving them some skip nights, kind of monitoring their nutritional status before we actually stop it. But for those people that the EC fistula has been kind of unresolved for a while. They've been on PN for a while, but you know what? They've started to eat. How do you really know? So, do they still need PN? That's a tough question because it's really difficult to know how well they're absorbing what they're eating. Trying to monitor their nutrition status is important here. I mean, obviously, that's not an easy thing to do. Weight isn't always helpful here. Well, often isn't helpful. So, you can look at your prealbumin and other indicators, but it's kind of hard to know if their nutritional status is adequate. You can look at fluid status, you can look at electrolyte status, with your labs. That's helpful. But sometimes it's hard to really know when to stop that PN totally. So it's kind of a gradual process. But if that patient is ultimately still going to require surgery down the road, even though they're still eating, we may need to use both. Still using supplemental PN for these patients because we want to maintain their nutritional status, especially that protein status, so that they have better surgical outcomes down the road. I hope that answers the question.
No, it absolutely does. So just kind of one last question to wrap us up. What advice would you give clinicians who are managing these complex fistula cases, really to support them in optimizing their patients' nutritional outcomes?
Well, great. Kudos for everybody listening to this podcast because hopefully increasing your knowledge base will help with management. That's the start, one start. But I would also lean on other experts in the area because, I've been doing this for a long time and I still need to get input from others with this. Obviously, like we mentioned, it's multidisciplinary. So identifying others within your institution or colleagues outside of your institution who you can go to for advice, I think is helpful, especially with the difficult cases where you just need some input. Another point of advice is to recognize the importance of controlled weight loss. And these patients who are obese, they will benefit from weight loss. We still want to be aggressive with our protein, but some of these patients need really low energy. The PN energy dose can be quite low, and it's kind of mind-boggling sometimes. I don't know if they're just not very active. Many of them, are in bed, good part of the day. But I've seen these people. It's like less than 1,000 calories a day, and they're not losing weight. So it can be a challenge to get them to lose weight. But we do want to have this controlled weight loss where we're aggressive on protein, but still getting them to an appropriate weight. And then another point of advice is to recognize how hard it is when we ask patients not to eat. And I mean, it can really have some profound psychiatric, depression, just some patients really struggle with not only do we tell them not to eat, but we're telling them we don't even know how long it's going to be. It may be 3 months, but it might be longer. And, that makes it really hard for them. If they had an endpoint, it would maybe be a little more manageable, but a lot of these patients really struggle with not eating. So when you have this patient leaving the hospital for the first time, obviously in the hospital we can control it. But when they go home, anticipate that they may end up eating and that may increase their output. So be prepared for that. We we set these patients up with supplemental IV fluid. We have them monitor their fistula output and report to us so that if we see that if it's higher than what it was when we were monitoring them as an inpatient, then we may either need to put more volume in the PN or we may need to give them supplemental IV fluid. So just to be prepared for that. And then finally, I do have a review article that I want to give a plug to that's in Nutrition and Clinical Practice in the February of 2025 um, issue that discusses the use of PN in the management of EC fistulas. So I would refer you to that.
Wonderful. Well, thank you so much for sharing all of this information. It's such a complex patient type, and people really need attention from clinicians such as yourselves and, of course, our listeners to thrive in this situation. So thank you so much for being here.
Thank you, Christina. And thanks to all you listeners out there.
And listeners, be sure to visit our website at dnsdpg.org. You can find a lot of nutrition support related resources, many of which are discounted or free for our members. And of course, you'll see some information there about our upcoming events at FNCE 2025. So we hope to see you all in Nashville. Until next time, I'm Christina Rollins. Thanks so much for listening.